Welcome, everybody, to Where Healthcare Begins, Rethinking Primary Care Access. We are so pleased to have Elena Gambon and Dr. Eric Bricker joining us today. Just a few housekeeping items before we kick things off. This webinar will be recorded, so please expect it in your inboxes sometime tomorrow. And we love questions, so please feel free to drop in any questions into the chat, and we will do our best to get to them at the end. And without further ado, I'll go ahead and pass it over to Elena.
Hi, everybody. Big warm welcome. Thanks for joining today's session. As Emily mentioned, today is all about primary care and better access to primary care. Before we dive in, I just want to ask if you're comfortable in the chat, you want to put what brought you here today, maybe where you're from, where you live. We get to know each other a little bit, get a good sense of maybe some of the questions that you hope to see answered and asked throughout this presentation. My name is Elena Gambon. I am the Chief Growth and Strategy Officer at First Stop Health. We are a direct virtual care company, and I am so excited to be joined today by Dr. Eric Bricker, who is a physician and an entrepreneur, and I think often needs no introduction because of how well known he is on the employee benefits circuit, due in part to his Healthcare 101 videos. I would venture to guess that almost everyone on this call has probably seen one of his videos. And I also want to share personally and professionally, this is kind of a cool moment for me. So I started my career many moons ago, before the gray hair that hopefully you can't see, as a patient advocate at a company called Compass Professional Health Services. And on my very first day on the job, we had Healthcare 101 training led by none other than Dr. Eric Bricker in front of a real life whiteboard. Now they're virtual. So it's just an honor having you here, Dr. Bricker. If you want to introduce yourself, welcome. We're glad to have you.
Well, thank you so much, Elena, and thank you to First Stop Help, and thank you for all of you for being here. I'm Dr. Eric Bricker. I'm an internist and medical school, University of Illinois at Chicago, residency at Johns Hopkins. Originally was a hospital finance consultant, actually, before going to medical school, and then went on to like I said, residency at Hopkins, and then started the healthcare navigation firm Compass that had wonderful people like Elena there, and we grew to over 2,000 employer clients, 1.8 million people that we helped navigate the U.S. healthcare system. And then we sold that business in 2018. I started making these AHealthcareZ healthcare finance videos. I've got over 100,000 subscribers. They've been viewed like millions of times. So if you feel like learning a little bit about healthcare finance, you can find it on YouTube and LinkedIn. And with that, I'm super excited to talk about virtual primary care today.
Awesome. And I will say, anytime anyone asks me, how do I learn a little bit more about this thing in healthcare? I usually send them to one of your videos. So cool. Thank you for the work that you do. We have three big goals today. Well, I mean, the first overarching goal is we want to keep you entertained. These things can get a little dry. So my goal is that you are riveted throughout the entire process. But the three big goals that we have for today is, number one, I want you all to walk away feeling like you have learned something new or feel like you better understand the state of primary care in today's US healthcare system. And I am going to make the argument that primary care access is actually one of the most critical issues facing not just patients, but employers today. So we know everyone's experiencing big medical renewals, but it starts with primary care. The second goal that we have is I want to prove to you that virtual primary care is just as, if not more effective than in-person primary care can be. And the third goal is I want to hopefully share some of what I know is the excitement that Dr. Bricker and I both have around primary care delivered inside of a value-based direct care model. And I want to ask you to start to think more critically about some of the hidden costs that you might be experiencing in your own healthcare journey, and what that can do, what misaligned incentives can do to the patient. So those are three really big goals. Dr. Bricker, I think we can achieve them in an hour, don't you?
Yes, absolutely. It looks like we got a super smart crowd, so they can take it.
They can take it. Okay, great. Well, we're going to start, I think, where most curiosity starts, with a definition. Let's get some shared language going. So, Dr. Bricker, can you tell us, in your words, what is primary care? What does it mean? What does it do?
Okay, so and I'll tell you that I have a little bit of a maybe even a different definition. But and it might come across as overly simplistic, but I actually think that it is potentially a good way to think about it, and that is a primary care provider has responsibility for the whole health of the patient. And so it is ultimately all of the health related issues for a person, which is why all people need to start with primary care. Because even if somebody needs a specialist, that ultimately, even that specialist's care is actually the responsibility of the primary care physician. And I will tell you, as a primary care physician, like I actually feel that way. Okay, so if like you are not like getting better, or you're having something that's a little like weird from your cardiologist, like I need to know
Yeah.
about that, and I need to weigh in about that, and I either need to talk to you about it, or I need to talk to the cardiologist about it, or I need to talk to both of you about it. It
Yeah.
is not just like passing you like a baton on from one doctor to the next. So it is and that full responsibility is the full accountability, which leads to the most important aspect of primary care, which is, and again, I'm going to get kind of touchy-feely here, which is love. It's really that ultimate concern for that other person. It's not the
Yeah.
ultimate concern for their lungs. It's not the ultimate concern for their kidneys. It is the ultimate concern for all of them. And really,
Yeah.
honestly, that's how all primary care providers actually think, is they
Yeah.
actually have concern for the entire person. And so I know that's a little bit of an atypical definition, but I'll stop there.
No, I love that. And I'm a big capital N nerd. So I obviously looked up in the dictionary the definition of the word primary, because I was kind of inspired by the concept of why do we even call it primary? And there's a couple of ways that the word primary comes into play. There's first in importance, basic or fundamental. And I think any way that you look at it, the intention is that generally primary care should be not just the first place people go, but it should be doing more than I think it is doing today. If I'm not mistaken, we've kind of gotten into this place where when patients see their primary care physician, there's kind of a referral heavy kind of world, and they are often sent to specialists pretty quickly. And I guess I'm wondering, Dr. Bricker, if it is so important that the primary care physician be that quarterback, why is it that patients are finding themselves sent to specialists more frequently and spending less time with that primary care doctor?
Yeah, so it's a great question, and we're going to get to it in more detail later on during our talk, but it really comes down to the payment system of fee for service, where the primary care physicians are honestly, majority of the time these days, they're given a quota. They're like,
Mm,
you need to see 4 patients an hour for 8 hours a day. So you got to see 32 patients a day.
right.
And you need to generate, your a bill for 32 patients a day. And that 15 minutes, by the way, only half of that is patient facing, because the other half is spent on documentation. So it is literally like only like a 7.5 minute visit. And it's because of the payment. There probably is not a single primary care physician out there that actually wants to have 7.5 minute visits with them. Like they don't want to do
Right.
it. They want to
Yeah.
be able to spend, because you cannot perform adequate primary care in that amount of time. You could be the world's best primary care physician and you can't do it. So,
Yeah.
especially for more complicated patients. And so to be able to have the time, right? Because, again, I'm going to get back to this love thing, as I tell the story about how I went to a wedding that was officiated by a hospice minister. And I'm like, oh man, this is going to be terrible. A hospice minister at a wedding. And it ended up being one of the best homilies I'd ever heard at a wedding, where he said that love is spelled Time. And so to really
Mm,
be able to spend the time necessary, you have to have a different model, a direct pay, a subscription model. So the
Yeah.
virtuality allows for people to get access no matter where they are, et cetera, et cetera. But then having it be not a claims based, to have it not be fee for service, then gives the primary care provider and the patient the time together necessary to actually provide the care.
Yeah. And primary care physicians go in to primary care so that they can do that. They're just fighting against a system that doesn't always let them do the thing that they need to do, which
That's
is
right. It's sort of
kind of
like
what we're trying to connect for. Yeah.
institutionally, the cards are stacked against them.
Yeah. Okay. So they should be doing more. There are obviously some times when you do need to refer out. If someone truly needs to see a specialist or needs some sort of surgical intervention or, needs an MRI, it's very clear that a primary care physician would refer them out. But what types of disease states are often referred out for, but are really well designed to be treated in the primary care ecosystem? Can you give us
Yeah.
some examples?
Okay, so I'm gonna phrase this in the way that we used to do our Health Pro training at Compass, where we'll go through by like organ systems, right?
Great.
Because there's a gazillion ologists, right? And at the
Right.
end of the day, your typical person, like they should not be expected to know what all these ologists are, right? You're busy and you're an expert in like, being an air conditioning and heating repair person, or you're an expert in being a school teacher, but you're not necessarily expected to be an expert in all of the ologists. And so that's where, like, when you get to the heart, okay, right, most people know what that is. That's a cardiologist, right? And at the end of the day, this is where hypertension is actually, if you go to a cardiologist for hypertension, they're gonna be like, why are you in my office? Like hypertension, it really needs to be managed by the primary care provider. And
Yeah.
likewise, same thing with high cholesterol, needs to be managed by the primary care provider. It's actually not going to the cardiologist that is the correct way of addressing that. Okay, so fine. And believe me, I'm not going to do every organ, but I'm going to do a lot of them. Okay, fine. So fine, so your hormones, your endocrine system, right? And the big one there is obviously diabetes, right? So you can certainly see an endocrinologist for diabetes, but the vast majority of people, especially with type 2 diabetes, they're best served by a primary care physician, because diabetes is a multi-system disease that affects your eyes, it affects your kidneys, it affects your nerves, it affects your blood vessels. And so again,
Yeah.
like, we're not just concerned about your insulin and glucose levels, we're concerned about all of the other organs that are impacted by diabetes. Also, endocrine does a lot of metabolic conditions, and of course, the most serious metabolic condition in America today is metabolic syndrome and obesity and the fatty
Hmm.
liver that goes along with it. And again, in terms of being able to have a healthy weight, like, again, that's bread and butter to what a primary care physician should be doing in their relationship with their patients. Okay, the lung doctor is a pulmonologist. Okay, listen, the vast majority of asthma should be treated by a primary care physician, not by a pulmonologist. Okay, obviously a skin, that's dermatologist. Again, I they have us rotate through dermatology during your residency, and literally like 80% of the dermatology visits, the dermatologist is like, why am I seeing this? They wouldn't say that to the patient. They would say that to me, like in the
They're
hall,
thinking it. Yeah.
outside of the room, but like, why is this person here? Okay, because
Yeah.
like for like rashes and eczema and acne, rashes, eczema, acne, like the vast majority of that does not need to see a dermatologist. Okay, for your digestive system, that's a gastroenterologist or a GI doctor for short, right? So there, your heartburn and even your chronic constipation and your diarrhea, and your acute constipation and diarrhea, like that's not really the auspice of a gastroenterologist. The big thing for gastroenterologists these days is that there's such a shortage. They're really just scoping. If you need an upper scope
Mm,
or an upper scope is called an EGD, and obviously there's colonoscopies as well. Like the GI docs,
right.
look, I scope people. Okay, and so if you need assistance with a lot of GI conditions that don't require a scope, then like the vast majority of GERD and constipation and diarrhea do not require a scope. And so that really needs to be managed by, and I promise I'll wrap up with just a couple more. Okay, fine. Um, like hay, like, I'm in Texas. Hay fever and allergies in Texas are horrible. Okay, you don't need to see
Yeah.
just for that. Okay, the vast majority of that can be done through a primary care doctor. And then lastly, there's more to it than this, but the last one I'll mention is the majority of of psychiatric medications are actually prescribed through primary care physicians. So for depression and anxiety, the vast majority of that is treated through a primary care physician. And what's great is that the medication, so the medications for depression and anxiety used to be like, and I'm talking like 30, 40 years ago, used to have a ton of side effects, and you had to do a really good job of matching up the medication with the patient, which is why the psychiatrist was so important for prescribing those. But
Yeah.
more modern depression and anxiety medications are so safe and so effective that it's actually, from an access standpoint, again, we're going to talk about access. It's like, what are you going to do? Are you going to wait 5 months to see a psychiatrist that doesn't even take insurance versus being able to get help with a primary care physician that might
Yeah.
be at zero out-of-pocket cost to you? So that delay causes deterioration in your medical condition that should not never happen. So again,
Yeah.
I could go on, but I'll stop there.
Well, and I think something we see a lot. So first off, health, virtual primary care is the world that we live in. And something that I see a lot in our patients is they will come into our virtual urgent care or our virtual primary care with physical symptoms like not sleeping or stomach aches. And then we run a panel of mental health questions and we spend time with them more than the 7 minutes learning about them and thinking about their issue. And it turns out there really is an underlying mental health condition that they just were not even aware of because it's showing up in the body. And
That's
so
right.
I think there's a benefit. I'm glad you brought up the mental health piece, because when someone understands that they need help and they raise their hand to talk to a counselor, that's an amazing thing. But a lot of folks haven't been given the privilege of learning about that, or aren't aren't necessarily even sure what's going on, and that's not their fault. The body's really confusing, but we just see so much that the physical and mental health of this is linked, and I think it's just a really healthy place to have that sit in primary care.
Yeah, and I'll just very briefly tell you, specifically that, in medicine, it's referred to as the differential diagnosis. When you're trying to diagnose somebody, you make a list of diagnoses from most to least probable, and then you kind of go through
Yeah.
from history, testing, et cetera, et cetera. You rule in and rule out various, diagnoses. And so for chronic abdominal pain, depression and anxiety are on the differential diagnosis for causing chronic abdominal pain.
Yep.
And again, many of you probably already know this, but outside of your brain and your spinal cord, the organ system that has the second most neurons is your digestive system. And so
Yep.
there is an incredibly intricate connection between your thoughts and your emotional state and how your digestive system functions. And so oftentimes they might perform an upper endoscopy and a lower endoscopy, and they're like, well, there's nothing anatomically wrong with your digestive system, right? Of course, there's nothing anatomically wrong with your digestive system, but unless you
Yeah.
address the entire person, then you're not going to be effective in diagnosing and treating them.
Yeah. And spending enough time with them to even get there is
That's
step
right.
one there. Okay. So primary care can do more. It should do more. How effective is it? Why, I think we've talked about this a little bit, about why can't a patient just go self-refer to a specialist. But can you give me any examples or patient stories of maybe someone that you knew or a patient you treated that specifically was benefited from a primary care physician quarterbacking a condition that they were experiencing?
Yeah. So there's a few dynamics to this. So one, in our post-COVID world, and we're going to get into more detail around this later on, is that frankly, that is when a lot of physicians stopped practicing. So there are about 1 million doctors in America, and about 100,000 of them during COVID stopped practicing. They retired. Most of them retired early. They were, in their 50s and 60s, and they're like, I've kind of had enough. I'm done. And so they just retired.
Yeah.
And we lost 10% of the physicians, many of whom were specialists. So now, if you try to self-refer to a specialist, you have to wait a really long time to get a new patient appointment. We're talking like a month, 2 months, 6 months to get in. And so, and that specialist has no responsibility to you. And so a lot of times people either they wait and they suffer unnecessarily just for that initial visit, or
Yeah.
two, their medical condition actually worsens while they're just waiting. And so,
Yep.
time is of the essence. And so just to be able to get in sooner in and of itself is hugely therapeutic. Okay. So you got to get in sooner. Okay. Then number two is that what has happened in medical training is that specialists have often become subspecialists and subspecialists. So they're not just a cardiologist, they are an electrophysiologist that only does arrhythmias. Or you don't just go to a neurologist, the neurologist just does headaches. They're a headache specialist. Or they just do dementia and dementia associated conditions like Parkinson's disease. I guarantee you the vast majority of orthopedists specialize. They're not a general orthopedist. They're like, no, I do knees and hips. Oh, I do hands. Oh, I do shoulders and elbows. Oh, I do feet. Oh, I'm ortho spine. And so it's actually relatively not straightforward for a consumer to know
Where to
what
go.
subspecialty they do. So you might be like, okay, my back is really hurting me. And unbeknownst to you, you could go to an orthopedist who specializes in knees and hips. And you're like, look, spines are not what I do. And
Right.
so that degree of subspecialization actually makes
I'm sorry, folks, but thank you so much for bearing with us.
we're just trying to figure out who's truly dedicated.
Yeah, right. Who's sticking in and going to go through all the hiccups to
Who
hear the
are the
wise
truly
words?
dedicated viewers who are signing back in to make sure that they can see? Look, all of you, listen, all of
There's a
you are
lot of you
signing
still.
back in.
That's
Thank you. I mean, this
incredible.
is unbelievable how many of you are signing back in. I
Yeah.
mean, so
If you're
it
ever
really
wondering if
means a
you were
lot to us that
loved,
you're signing back in. This is wonderful. So, Elena, take us on, to the
I
next
will.
topic.
All right. But I will say, point well taken. I think it is very important to start with a primary care physician. One thing I want to talk about, though, is the fact that almost nobody is actually going to see a primary care physician. And I say this both from data that I've gleaned looking in the commercial insurance environment and also just looking at all of the clients' data that we bring on at First Stop Health. It is so common for me to see less than 20% of the population having had a primary care visit or any type of wellness visit in the last 12 months, 24 months, 36 months. If you look nationally, 60% of US adults don't have or haven't seen a primary care doctor, and a staggering 92% of US adults are not receiving 100% of their preventive screenings. And I just want, I think you're going to answer the question as it relates to access, which I think is an important piece, but what's happening? Like, why is this happening? And why is this so prolific among employers when it is so clear how beneficial this is?
Yeah, so there's a few things going on for why a person does not see a primary care physician. So one is it's a combination of, okay, the individual patient themselves is just not initiating seeing a primary care physician. And then there is, okay, well, even if they initiate trying to see the primary care physician, that there's some sort of barrier to actually seeing the primary care physician. So there's kind of two big categories. Okay. So
Right.
kind of the lack of like interest in sort of seeing a primary care physician is, believe it or not, the American Academy of Family Practice and the American College of Physicians, so family practice physicians and internal medicine physicians that essentially perform primary care for adults, they've been trying to actually do better, quote unquote, like PR, like like just making
Mm,
people aware. People are just not, it's just not part of the quote unquote educational process. Like everybody knows when you're a
yeah.
kid, you go to a pediatrician. But
Yeah.
like at a very basic level, there has never been a partnership with the American Academy of Pediatrics to say, oh, when all of your patients turn 18, you need to tell them that
Ship
they
them
need a
on
primary
over.
care physician, and then you actually need to handhold them to a primary care doctor once you no longer see them in their practice because they've aged out. Like that,
Yeah.
like that process like doesn't exist. We also have a lot of people who from we have a lot of people who from um their nation of origin their own like healthcare in their own home country. It was like it was run by the government and it was free if you went to the emergency room. So everyone's like, oh, you just go to the emergency room for everything. That's just like
Yeah.
what you do. Like you don't even try to get a primary care appointment in XYZ country because that's not how it works. Like they might have primary care doctors in the emergency room, but like you just go to the emergency room. Like, that's just what you do. And
Yeah.
so they may be a first generation American, but they might even be a second or third generation American. And it's like, the habits of the father are passed on to the son or the mom to the daughter, right? And so it's like, well, that's what mom and grandma did. So that's what we're going to do too. So fine. So they didn't initiate going to see the primary care physician, but even for those people that do initiate trying to see the primary care physician, that's where again, issues of access are hard with primary care physicians as well. And so I don't, do you want to go into the access stats now?
Yeah.
Um,
Yeah.
we're
We
just,
have
and
some
again, this
statistics
is
to share.
a post-COVID world thing that maybe many of you are aware of as well. But so this breaks down by specialty how long people need to wait to make a new patient appointment. And so starting over on the left, it's ranked by sort of the shortest amount of time. And so this is where orthopedic surgery is the shortest amount of time at 20 days, right? So we're talking like 3 weeks to see an orthopedist. Okay. Like general surgeon, 22 days. Okay. Pediatrics, 24 days. Fortunately, most kids have an established relationship with a pediatrician. So you're not waiting 24 days to get in. Okay. Look at that. Even for the first primary care specialty to pop up is family practice. And even there, it's a month. Okay, so even if you want to see a primary care physician for as a new patient appointment, the vast majority of people are like, I'm not really going to wait a month. Obviously, you have some everybody on this call, of course, people who are very proactive about their health and know that they need to get their screenings, et cetera, et cetera. And so there you might be like, okay, fine, a month to wait for a primary care appointment, that's fine. But obviously, the vast majority of the employee population is not like the people that are on this webinar. And so typically it's like an itch and a scratch. Typically it's driven. So typically there's something going on, and whether
Yeah.
it's a specific, like I said, abdominal complaint, respiratory complaint, etc., um, or it could even be a mental health, behavioral health issue. So even there, it's a long time, right? Look at that. Cardiology, 39 days, dermatology, 40 days, and then gastroenterology, 48 days, and then for neurology and rheumatology, it's over 2 months. And
Yeah.
so getting into a specialist is super hard. Getting into a primary care doctor is super hard. Like it's just hard across the map. Now,
Yeah.
I bring up map because it also varies geographically. So we talk about how, I'm sure all of you have heard about rural health being an access problem. I will tell you, access is a problem in metropolitan areas too. This is not a rural health thing. Okay. So now we have
Yep.
metropolitan areas listed in decreasing wait times for first patient appointments. So the lowest one is Houston at 27 days, at almost a month. And then New York City's at 28 days. Okay. You would think at the Big Apple, with so many people, they're like, oh, they don't have nearly enough providers. But the good news is that there's a ton of medical schools and residency programs in New York City. So they've got gobs of doctors in New York City for all those people. Right? It's 20 million people living in the New York City area. Phoenix is at 31, Dallas at Fort Worth is at 32, Philadelphia 36, Washington, D.C. 36, Chicago 39, San Diego 41, Seattle 44, Minneapolis, St. Paul 45, and then look at this, Boston 70.
Yeah. Ripe with
70
specialists,
days
but not a lot
in
of primary
Boston.
care
And
doctors.
here and Boston specifically is a primary care desert. Okay,
Yeah.
almost everybody in Boston is a specialist because they have so many high-ranking academic
Academic.
institutions. Nobody goes to
Yeah.
Harvard to become a family practice doctor. So they don't have a lot of primary care doctors there. And so
Yeah.
it's just super, and then so many of the specialists in Boston, they do research So they don't spend 40 hours a week or 50 hours a week seeing patients. They might only see patients 10 hours a week because they're doing their research for the other amount of time. I'm not disparaging them for doing that research. That's fine, but it just creates a patient access problem in terms of being able to get in to see the doctor. So and
Yeah.
we experienced this at Compass in terms of helping people find physicians over the course of 11 years for
I
1.8 million
remember.
people. Is the two major things were location and appointment availability. Because people, to a certain extent, it's like it's hard to get there for transportation purposes, or frankly, a lot of people, understandably so, like they don't necessarily want to drive to a part of town that they're not familiar with. Like I don't want to say that they're xenophobic, but they're just like, look, it's confusing. I don't like driving places that I'm not familiar with, so they don't necessarily want to go there. Or in places in all these cities, even if it's only 10 miles away, the traffic could be horrible, right? The traffic could be so bad that 10 or 15 miles is like, I'm like, I don't have 45 minutes in each direction to spend in traffic because I've got so
Yeah.
much that I
Or they
need to
just
do.
won't go. Yeah.
Right. So it is.
And,
So
yeah.
so it's appointment availability and location are the top two. And then interestingly, the next one after that is cost, right? So they
Hmm.
don't even consider how much it's going to cost them unless it's like, okay, is it like at an appointment time that is like good for me and can I get to it? And then only after that was cost. And guess what was a distant number four was actually quality, because the overall assumption, which is actually not correct, is that the quality of all physicians is the same. And so they weren't even thinking about that. And so they could end up at a, and it's a bell-shaped curve. Okay. We do not live in Lake Wobegon. Not everybody is above average, right? And so there are absolute, and every doctor will tell you this, there are absolutely people that we went to medical school with that we would not necessarily want our family members going to see. Okay. But you might see that person because they have appointment availability and they're close by. And it's,
Yeah.
a $5 or a $10 copay. And it was actually a bad idea to go to
And
go to
there's
see.
no way to know if they are good or not. There's just absolutely no data for a patient to access on their own to be able to steer to that.
That's right. And so this is where it is super important to make things. And again, I'm in no way saying that quote unquote patients are lazy. Everybody is busy. They shouldn't have to be experts in quote unquote finding medical care. That shouldn't be in their like list of skill sets. Like you got to tie your shoes. You probably should be able to know how to swim. You probably should be able to know how to ride a bike. Right? There's some basic things that you should need to know. Like doing effective personal healthcare navigation to the correct ologist is not something in the compendium of adult knowledge that you should have.
We
Like
got other stuff that
I
we're
don't know
worried
how to build
about.
an iPhone. I shouldn't be expected to know how to build an iPhone, right?
Yeah.
Okay.
Yeah.
So you as a person should not be expected to be able to figure this out on your own. So this is where the primary care physician is the iPhone. Okay, right. Like understanding who's good and who you need to go to and when to see them and when you need to wait and when you don't need to wait or whatever. That is all within the expertise of the primary care physician. Anyway, I'm going to stop. Zoom's going to cut me off and tell me that I'm being long-winded again. So I'm going to stop.
Well, no, but the point that I also want to make here, which I think is important. So it is cost, it is availability, it's wait times. I also think there's this psychology thing going on where human beings are built to care about the thing right in front of them. The pain that they are feeling right now, not the pain that they might feel in 20 years. That's why it's so hard to get people to contribute to their 401k.
Right.
And so one of the things we run into a lot is, and again, not to blame the patient, but there just is this inertia thing. And so when at First Stop Health, when we think about primary care, we think about it as the thing that you get a patient into after you have built trust with them when they come to you in the middle of the night for a UTI or because their kiddo has an ear infection. You have to kind of grab their focus and their intention and their trust when they've raised their hand for the problem and then move them into a state of thinking about prevention. And that's kind of how you build that trust, because and I've heard you say this before, like most people are not sitting around thinking, oh my gosh, I have to get my A1C levels under control, right? It's just, it is a long-term mindset that people have not developed. And that's just, it's biological. It's in our nature to care about the worries that we have right in front of us. And primary care has this connotation around being, future focused, more holistic, and honestly, I think less delightful than it should be, because people also don't do things when they're not enjoyable. And most primary care right now is not only hard to access, but it's kind of a pain. to deal with. And I think
Well,
that's an important
and
thing
I
to
will tell
fix.
you that, so to that end, I was just speaking at an employer event here in Dallas. It was last Tuesday, and one of one of the HR guys, had been in, large corporate HR for his entire career, and his entire, he's like, look, the the mentality of myself, he's talking about it himself, is that at the end of the day, like, why is taking care of my employees' health, like, why is that even my business? Like, that shouldn't even
Mm,
be my business. And he was saying that rhetorically, and he's like, well, I'm paying for it. So at the end of the day, I kind of have to make it my business because I'm writing the check. And so
mhm.
and of course he was thinking, like, in this, like, this la la land, he's like, ideally I wouldn't pay for it anymore. He's like, I really don't think employees' health should be any of my business, but I also don't think I should have to pay for it. So he was trying to just get rid of the whole thing completely.
Yeah, live
It's
in a different
understandable. I'm
universe.
sure
Yeah,
a lot of people on
yeah,
this call want to be able to get rid of it completely, but that's not the world we live in. And so it's
right.
like, if you pick up one end of the stick, you got to pick up the other end. So we're picking up the
Yeah.
end of the stick of having to pay for it. And so, unfortunately, by definition, if we are going to have to pay for it, then we got to be involved in it.
It's a nice soundbite. I couldn't agree more. And I think, we think a lot about trying to make sure that we are investing upfront in getting involved in it, right? And it can't just be a reactive experience, which is where primary care comes into play. I want to shift a little bit to talking about primary care delivered virtually. And specifically, I want to ask you a question that we get a lot. And I think it's a really, really good one and a really hard one to answer, which is, how can you possibly effectively deliver primary care in a virtual setting? Don't you need to palpate someone's lymph nodes and listen to their chest sounds to treat them holistically the way that you've described at the beginning of this call?
Yeah.
How do you do that virtually?
Yeah, so it's a good point. And I think the important thing to keep in mind is not the theoretical approach or the rhetoric around that, but to actually look at, like, what's actually happening. And so the way that I look at primary care is, I don't make a distinction between I don't the first distinction I make is not between virtual and in person. The first distinction I
Mm,
make is it fee for service or is it direct? That's the distinction.
mm,
Okay. And
mm.
so, historic fee for service primary care we've already talked about the shortcomings of that. Okay, so now let's talk
Right.
about subscription based direct primary care, where the employer is paying for access to a primary care physician on behalf of the employee and their family members. And then those employees and their family members are then accessing that primary care at zero out of pocket cost to them, for unlimited use, and there's no
Mhm.
claims being generated. It's essentially a subscription model for access to primary care. Now, this is not new. So direct primary care has been going on for 20, 25 years now. Interestingly, it actually started in places like Washington State and Kansas. And then the states, and direct primary care has really, there's pockets of where it's really, really taken off. And it's really
Mm,
taken off in Colorado, and it's really taken off in Wisconsin, and it's really taken off in Indiana, and it's really taken off in those states specifically for the employer sponsored population. So this is where employers are signing up their employees with primary care. Okay, what do Colorado and Wisconsin and Indiana have in common? They have something in common. They have incredibly high healthcare costs because the hospital systems in those states are incredibly dominant and have incredibly high prices. So Indiana University in Indiana is one of the most expensive hospital systems in America. The University of Colorado hospital system in Colorado is one of the most expensive hospital systems. Their prices are just much more. And
mhm.
so there, the employers are like, we
We got to
can't
get ahead of
use
it.
them. It's gotten to the point where it's prohibitively expensive. And
Right.
so, like, if you go to a school system in Indiana and Wisconsin, and you go to a municipality in one of those two states, like, almost all of them use direct primary care. Okay, so fine. So there's direct versus fee for service, right? And then within direct, what actually ends up happening with how that, even for the patients that are, like, in their town, they end up providing upwards of 70% of the care virtually anyway. because
Why is that?
it's like, even if you're, look, yeah, you're 20 minutes away, but you're
Yeah.
busy. You're a working mom. What working mom has 20 minutes? There's not a working mom in America that has 20 minutes. Okay.
That's so true.
So they deliver it virtually where they can. And so
Yeah.
there are going to be certain medical situations, either based upon the history, right? Because you're still going to be able to get a history to say, okay, listen, here are some situations where I actually do need to perform a physical exam. And obviously, in a virtual primary care environment, you are not capable of performing that aspect of the physical exam. And one of those might be like true respiratory distress. Okay.
Right.
And you can actually visualize the respiratory rate of a person, and you can see if they're using what's referred to as their accessory respiratory muscles, like their scalenes. Here, you can see if they're doing that
On the video.
on
Yeah.
the video. And so
Yeah.
you'd be able to say, look, you're in a breathing situation where frankly somebody needs to listen to your lungs. So you do need to go to an urgent care or to an ER to actually have that done.
And that's a right now problem. That's not a wait a couple of days to see a primary care physician in person. That's
Yes.
either way, they need to be seen right now if they're in distress.
That's right. And I will even add too that that is the minority of those situations. Now, the
Right.
what's interesting is that many virtual providers have actually done a lot of good work in terms of the self-guided physical exam by the patient themselves. And one of the places where this is actually fairly helpful is in orthopedics. Because if you have like a sprain or a strain,
Mhm.
again, this is more medical information than you guys want to know. You're like, I did not come to this to go to medical school, Dr. Brigger. Okay, but it is that you use the function to test the structure. So you
Yeah.
use the function of the tendons and the ligaments to figure out which tendon or ligament is actually sprained and the degree of the sprain. So they might have you do things like, okay, turn your arm up. You can't see my whole arm, but turn your arm upside down like this. Now, how does that feel when you do that in your shoulder? And that's going to actually give you a better understanding of how the rotator cuff may or may not be. And the rotator cuff are the tendons and ligaments of your shoulder. Well, how your rotator cuff may or may not, or they may say, look, so video is helpful. Let us look at the range of
Yeah.
motion in your knee. Let us look at the range of motion in your ankle. Are you weight bearing? What degree of weight bearing status do you have with that? Okay. So
Yeah.
some things you can just do over the phone, but the video can be very helpful with a self-guided exam as well. So virtual primary care is never meant to address 100% of everything. So no solution is perfect, but then you're asking yourself the question, okay, well, so what's the alternative? The alternative is they're going to unnecessarily go to the ER, or in the opposite direction, they're going to
Do
wait too
nothing.
long to go in to see a primary care physician or a specialist. They're going to wait 3 months in Boston.
Yeah. Yep.
So it is a tool that is used today by direct primary care physicians. And every single direct primary care physician that you would talk to would say it is a hugely important tool for them.
Yeah. Something I'm really excited about is we have a really strong eye on the market for epidemiologically sound data that proves that there are cases where virtual care is actually more effective in some circumstances. And there's a study that I wanted to just kind of share with everybody right now. If my team could navigate to it, thank you so much. It was a study of 500 patients in Pennsylvania and Maryland, and one cohort only had in-person primary care. The other cohort only had virtual primary care. And the researchers analyzed the outcomes across 16 different HEDIS metrics, which, for those who don't know, those are pretty standardized quality metrics set by CMS. And what they found was in 11 of the 16 different metrics, virtual care statistically outperformed in-person care. And those metrics were on people completing their preventive testing and counseling-based metrics. There were 2 medication-based metrics that were the same. There were only 3 metrics where in-person was actually better. And this study is one of a number that we've been able to kind of follow as virtual primary care has become more popular, because it is relatively new in this age of becoming more comfortable with video visits. And I think we're going to start to see more and more of this data show up, which is you literally can do the thing primary care is intended to do virtually, which is make sure you're getting people's diagnoses, make sure that they're actually getting in to see the physician, having them adhere to care plans, and getting their preventive exams, which is so important for reducing long-term risk. So we think this study is so cool because it's just really clear and statistically sound.
Well, and just practically speaking, what happens is there are employers that have employee populations that just by the nature of their business, they have highly geographically dispersed employees. Like,
Yep.
first and foremost is like retail, where, yeah, they've got a headquarters where they might have, several hundred or even several thousand employees, but then they
Yep.
have, hundreds of retail locations across the country where each retail location might only have 20 or 25 employees, or each retail location might only have 100 employees. And so there, it's really not feasible for them to create any sort of like contracting relationship with like hundreds of direct primary care practices across the country. It's just not practical. And so, so retail and for hospitality, and even for some folks that are like oil and gas, where they're like literally out on a rig, or they're out, out in the Gulf of Mexico, or they're out, in West
Yeah.
Texas or North Dakota or whatever, where it is. So now, so when I talked about, Indiana and Wisconsin, right, municipalities and school systems, they have geographically concentrated, but there's a lot, but especially with remote work now, there's a lot of employers where their employees are just spread out, where frankly, it's like, okay, if we're going to have like a practical solution where we're not going to contract individually with hundreds of direct primary care clinics, then virtual is the way you have to do it.
Right. And I think it gets back to the point you made earlier, which is it is this intersection of virtual and direct care, because the direct care model, what we love about it is so much of the problem in healthcare is arbitrage, is there's glut. There's no way for an employer to follow the money that they're paying in how it's going through the system. And the beautiful thing about a direct care model is you know exactly where your money is going for the services that you're getting. And then ideally that direct care model is also coupled by some sort of at-risk value-based payment arrangement. So for First Stop Health, we put 100% of our fees at risk for people to use this, because literally having the visit with the primary care physician is extremely important. But then there's just this level of accountability that it affords. And to the point you made earlier, it kind of disrupts some of the problems that exist in the fee-for-service system around provider time. Instead of spending 15 minutes after every visit coding to get reimbursed by the payer, they're actually in that clinical time with the patient, and they get to spend more time thinking about the patient relationship and less on some of the administrative overhead that healthcare has created for us.
And also too, and this actually helps scale direct primary care as well, because actually from a recruiting standpoint, it's actually much easier to recruit a physician to a direct primary care practice, whether it's virtual or in person, because like, oh yeah, you don't have to code for billing. I mean,
they're so happy.
You don't have to document for billing. You can just document for clinical purposes, to actually say what transpired during the visit and to be able to communicate with other clinicians and not have to do it for insurance or for billing purposes. That they're like, oh, and also to be able to have like longer unrushed visits. So it's actually much easier to recruit for direct than it is for traditional fee for service primary care. In fact, a lot of these physicians, they're getting out of fee for service and they're running like mad over to the direct world just for lifestyle and burnout reasons. So the other thing that is important to keep in mind is what you just said, which is that any direct primary care solution only works if people use it. And so to have vendor alignment around where when the patients win because they're using the services, when the employer wins because the members are using the services, and that needs to be aligned with the vendor winning in terms of their fees. And that's super important. And to a certain extent, I'm going to put Elena's words in Elena's mouth too, is it also helps with the accountability of all of the employees at the vendor, so that if it's 5 p.m. on a Friday or whatever, they're like, whatever, just go to the ER, I'm checked out. It's like, no, we got to hustle here, right? This is services business. All right, you got to hustle. All right, I mean, elbow grease is of super importance, and so you need to have the whole company financially aligned for that elbow grease, because everybody who works in healthcare, whether you're a doctor or a nurse, like, that there are people who don't hustle and they drag their feet. and they just turf patients to other people. And so you need to have a provider environment where you're hustling to do the right thing for people, and to financially align that between the vendor and the employer is super important.
Yeah, the ball goes where you're looking. I mean, if the leadership is not regularly looking at the outcomes for which they are financially responsible, things aren't going to get done. And I mean, you just have to build it into the system so that everybody cares and is moving in the same direction.
That's right, because right,
Yeah.
as we have it today, fee for service is a completely unaccountable way for payment, right? It's just like,
Yeah.
whether I did a good job or a bad job during my 7.5 minutes, it's of no consequence because
Yeah.
I'm going to get paid no matter what, right?
Yep.
So the whole reason why I'm here on this call today and why I do the work that I do is because the way that healthcare is structured in America today is in of itself a public health threat. Okay, so I look at all of you as employee benefits professionals. I look at you as my teammates in being public health professionals. It's akin to like unclean drinking water. Okay, the financial misalignment and the fragmentation within healthcare is detrimental to people's health, the same way unclean drinking water is. And it's
Yeah.
beholden on us. Like, believe me, Elena and I aren't going to do it alone. You know, none of you are going to do it alone. Like, we need a lot of people working together to address this, because it's like, well, you know, we got unclean drinking water and people are just going to get dysentery and die. That's just, you know, that's just sad, right? No, no, you do something about that, right? You don't just say,
Yeah.
oh, well, people get dysentery and die. No, you do
Yeah.
something about the drinking water. And so
Yeah.
I'm so passionate about this because I've literally seen people like suffer and die as a result of this. And I can't,
Yeah.
like, there was a guy at the VA, he was a gunner in a Huey in Vietnam, and literally he could not get in for his pancreatic cancer. And I saw him die from his pancreatic cancer. And you can't see
Yeah.
that and not become passionate about doing something about it. So anyway, I'm
Yeah.
gonna stop.
We have a moral obligation. I believe if you are in healthcare and you are in the business of healthcare, you have a moral obligation to remove as much glut as possible and create access and do whatever you can to hold yourself accountable to that. We have 5 minutes left. This has been so fun talking to you. I do want to make sure we get a couple of questions from the audience before we close out. And I did see one that I think is a really important one, which was someone had asked if we could kind of clarify what we mean when we say the existing fee-for-service system is not only discontinuous, but there's a lack of clarity around where dollars go when insurance tends to get involved. So Dr. Bricker, I think this might be a good question for you to answer, which is, what do we mean when we say that there is kind of this arbitrage in healthcare? There's this like black box of money flow when it comes to both medical and prescription costs that employers are accountable
Ooh,
for.
okay, good. This is a webinar in and of itself. Okay, we're gonna deliver
I
that
know,
in
right?
4 minutes. Okay.
That's
Okay,
all you need.
at the end of the day, you know, this is one of the prime reasons why employers need to be self-funded. And historically, the carriers have not given claims detail over to the self-funded employers so that they could actually examine it for fraud, waste, and abuse. The carriers essentially have their own quote unquote FWA departments inside of them, and you as an employer, you just need to trust them. Fine, trust them, but verify. Right? There's no verification process for the trust that they're actually identifying fraud, waste, and abuse. And so to be able, I mean, there's a ProPublica article where Southwest Airlines, as a self-funded plan, had a personal trainer, like a weightlifter, who billed millions of dollars of physical therapy claims for doing weightlifting with Southwest Airlines pilots and flight attendants. Okay. And guess what? When they found out, I mean, they didn't find out about it, so ProPublica did an article about it, and they fired their carrier and got a new one. Okay. So, like, to say that fraud, waste, I mean, it's upwards of 10% of claims. Okay. Just know that fraud, waste, and abuse is estimated to be about 10% of claims. Okay. And you can look on an AHealthcareZ video that I did about Quest Diagnostics for their own employees, where they had their own doctor running their health plan. His name is Dr. Steve Goldberg, where he actually got the claims from Aetna, and he was telling Aetna about the fraud, waste, and abuse on his plan. And he would have a meeting with them every 2 weeks where he would tell them what they needed to fix. And again, I'll stop there. But it is, you know, that's a whole nother can of worms. I mean, it exists.
It is.
You as an employer are absolutely paying for claims you shouldn't be paying for.
Yeah, and there's so many ways. The number one way to start to solve for that is to get your hands on as much data as possible and align yourselves with partners who are credible and are very transparent about kind of how they get paid and what they do. I think that's extremely important. I want to close out with a quote. And this is a quote from an individual by the name of Dr. Julio Frank, who is the former Minister of Health of Mexico and the former Dean of Harvard School of Public Health. And his quote is, "A strong primary care system is the immune system of a nation, silently working, often unseen, there to prevent collapse." So, Dr. Bricker, if you have any final thoughts on topic of primary care, the importance of direct primary care, the value of care delivered virtually, specifically for employers, I'd love to hear it.
And that exact same approach is not only applied to a nation, it's applied to an employee health plan. And so it is the sort of the call to action, if you will, around this is actually, as all of us as employee benefits professionals, it's actually to engage with the executive team outside of HR around thinking about these issues and thinking about not only where the dollars are going, but thinking about how that relates to care delivery. And, you know, to not boil the ocean, but to have those conversations over time, because really all of the best, you know, because believe me, employers have like solved this problem. Like, so whether it's Purdue University, who's kept trend flat for 3 years, whether it's the, you know, Saragraph in Wisconsin that kept trend flat for 9 years, like there's a suburb of Denver that kept trend flat for multiple years using direct primary care. Like it's been done. Okay, this is not a theory. This has actually been done. And in every single one of those situations, the HR departments have always had involvement with the executive teams around it. And they've had to build that over time sometimes. You know, Rome's not built in a day. So to the extent that you have an opportunity to do that, then it really is going to frankly improve the health and alleviate the suffering of the employees on your health plan. So that's what I would leave you with.
So well said. A perfect place to leave it. Dr. Bricker, thank you so much. This was extremely fun to do with you. And this passion that you feel, I share. I mean, it is about cost, but at the end of the day, there are real human beings with family members and kids and pets on the other end of this. And you just have to care enough to try hard and do the right thing. So we're really grateful for you all spending some time with us. Thank you for hanging through the tech hiccups. It just made it more exciting. But please give us feedback, ask us questions. We're totally welcome to it. And I hope you have a wonderful rest of your day.
All right, buddy.
Bye, everybody.